Excellent. Thank you very much. It's a pleasure to be here. It's somewhat daunting not being a researcher per se myself to present to a room full of researchers, but the terms elegant do not reflect what the research we have done is. It's more of desk-based research. So if you think about the kind of research that was presented this morning, look at humans, biomedical or psychosocial research, this is not what we have done. It is not research about health systems or implementation, but it's a self-reflective type of research for researchers to inform the agenda for research into HIV and aging. So it's research looking at what research is being done nowadays in Canada on the subject of HIV and aging. So to give a sort of a big picture context. So in process, Canadian research on health, aging, and HIV. First, some acknowledgements. CIHRRC is fortunate to have funding from the Public Health Agency of Canada to provide Secretariat support services to the National HIV and Aging Research Working Group and a parallel National HIV and Aging Coordinating Committee. That money funds my 2-day-a-week position and has also allowed this research to be undertaken. So thank you very much. Objectives were simply to create and make publicly available an inventory of in-process research related to HIV and aging in Canada. So to pull all the information together from a number of disparate sources so that people, different stakeholder groups, could see what was being done and help inform what their part in moving the agenda forward is. And so the objective was to systematically identify and provide some sort of preliminary and limited analysis of what research activity is ongoing. And so this was done this year in the months of January and February. We did a search of publicly available information, basically on internet databases. And for those of you who are researchers or who have tried to inquire into what research is going on, what's actually out there in the public domain is quite thin. But our resources did not permit us to follow up with each researcher and request a detailed documentation of what they had proposed to do. So it was publicly available information, and you'll see listed there some of the sources, which numbered 62. And it was hand searching, so clicking through websites, keyword searching websites, and then for research databases like the CIHRRC inventory, we were actually able to use search engines within those databases to pull research related to HIV and aging. And our search terms obviously were broad enough to include comorbid conditions that affected people aging with HIV. And so the final step was coding this information, and thanks to our colleagues at the Ontario HIV Treatment Network, in particular Laurie Chambers, who led a scoping review, and the, I think, positive healthy aging review team, the team they brought together, they provided us with some excellent codes in terms of health domains, which we'll see subsequently, and categories within 6 of those health domains. So that was an essential building block. It meant we didn't have to develop that step of how do we understand what we found. What did we find? Our results. We found 85 funded research activities since the beginning of 2010, accounting for approximately $16 million of funding. Not surprisingly, CIHRRC was the predominant funder, 59 of 85 in terms of numbers, but the overwhelmingly prominent funder in terms of actual dollars of the research related to HIV and aging. In the process of coding by health domain, some research spanned more than one domain, which is not surprising for a couple reasons. One is we've recently had some very big, large team grants that dealt with comorbidities, and the nature of that request for proposal was that they would be somewhat holistic or cross-cutting. The other is when researchers set out to conduct research and it gets condensed to an abstract, their central question may span a couple health domains, physical health and mental health. So that was coded as 2 record for our purposes so that we could properly assess what research was going on in the physical health domain and in the mental health domain. So what did we find? We found there was a predominance of research across physical health, mental health, and health services, and this accounted for 84% of the research activities. And then stepping down, 14% of research fell into the domains of social participation, antiretroviral therapy, and sexual health, and the other were training grants for residences or to spur clinicians to become researchers. So they're in the nature of interprofessional training. So physical health being one of the big three, if we break it down, we'll see physical well-being was the overwhelming category into which research fell. It is quite a broad category. Just to give you a bit of the flavor, some of the key words, which were our third level of coding, would be disability, rehabilitation, polypharmacy, social and cultural dimensions of health, survey instruments. So quite broad. So when I said it's not so subtle, it's not so subtle. We'll have to wait for the results of this research to actually get a better handle on what was inquired into, because we are looking at research that has been funded but not yet producing data. In the mental health domain, we have a lot of neurocognitive issues, so the column on the left, and skip one over, and then psychological well-being, which once again was quite a large catch-all category, similarly keywords that reflect a fairly holistic or broad spectrum of health. Notable, substance use was only being looked at in one study, and mental health conditions per se, so the concepts of depression, bipolar, things that are diagnosable, were only being looked at in 4 proposed research or funded research. Moving to the third of the big categories was health services research. And these categories, as you can see, tend to be quite general by their nature because they're not focused on a specific biomedical condition or intervention, but rather relate to somebody's interaction with an institution or system or professional. And so not very specific in focus, at least in terms that we were able to appreciate from what is available publicly. So some of the key words in health services were aging, Aboriginal health research, social and cultural dimensions of health, community-based research, food insecurity, which has been mentioned earlier today, social support structures. So, given that what we were looking at wasn't very specific, and given that there is no articulated HIV and aging research agenda in Canada, it's kind of hard to come up with concrete conclusions. So please accept these conclusions as tentative and suggestive of further thinking around this issue. We hope that these conclusions can help those with a stake or an interest in HIV and aging research better appreciate the volume and focus of the research that's currently underway in Canada. And this is one part of a broader examination. Obviously, a literature review would help clarify what has actually been done. So this was what is funded and in process. It would also be helpful to know what was previously examined in Canada. The OHTN scoping review gives us an international perspective, but to drill down to see what happens in Canada as well would be another piece of the knowledge puzzle to get a handle on where we're at with creating knowledge. And hopefully these conclusions might help elucidate further areas of inquiry or questions in need of research and examination. Our final point here is sort of a plug for something we think really needs to be done, which is a national survey asking people living with HIV what their concerns and needs are to inform the research agenda. Up until now, that has not been done, and we think that's in need of doing. And moving up the sort of conclusions bullet by bullet, perhaps people living with HIV and aging with HIV, given the uncertainty, complexity, and unknowns, will actually have a more fulsome definition of what health is, which better accounts for a broad definition like the World Health Organization definition. And by asking a broad base of people living with HIV, if selected and stratified properly, we'll also get a sense of particular interests and questions by socio-demographic factors. Age, well, age is, because we're talking 50 plus, and my time is up, so I'll wrap up in a minute. We're talking 50 plus, but as amongst people who are 50 to 60, 60 to 65, 70, there may be different concerns. As amongst people, Aboriginal people living on and off reserve, people who are migrants to Canada, people who are Canadian native born. So by asking people living with HIV, we may get a better sense or texture of what the important questions are. Final 2 points. It's about HIV, aging, and health, but the way things have been funded up until now tends to be through the lens of comorbidities. Aging lives under comorbidities in the Canadian health landscape. And so it's a lot of the research reflects a focus on comorbidities, not necessarily whole person aging or concerns related exclusively to aging as a socially constructed concept as opposed to a biomedical concept. And finally, I think it's fair to say that $16 million, not insignificant since 2010, there's a significant volume of research related to HIV and aging. Thank you.